आपको ही गए पैसा लगाता है टाइमर लगाता है पैसा लगा नहीं ऊपर टाइमर लगा रहे होगा वो वो सोलर में टाइमर लगा
Yeah, Dr. Raju, you can switch on the video now. We are starting the meeting. Yes. So, welcome friends once again to Saturday Club of Baroda meeting. And today we have with us Dr. Rajiv Bhatt, who is very well-known oncosurgeon. We have had him as a speaker when the meetings were held offline and even online also. He had given a talk on breast cancer a couple of years back. So to formally introduce Dr. Rajiv, he is oncosurgeon based in Vadodara, director and head surgical oncology services at SCG Cancer Center, Vadodara. He was trained at Tata Memorial Hospital, Mumbai, and he had done his fellowships at MSKCC, New York and Nottingham, UK. He worked in South Africa for 3 years from 2009 to 11. And to his credit, he has numerous publications, lectures and orations. And to his credit, he has pioneered specialized breast cancer surgery in Vadodara, about which we had learned last time when we had him here as a guest speaker. So today he is going to talk about a very interesting topic, that is robo-assisted cancer surgery, the current status. So over to you, Raju. Thank you for joining us.
Thank you very much, Satish. Thank you to the Saturday Club members also for having me here again. I will share my screen shortly, but I have taken, Satish, the liberty of slightly modifying the title to more correctly reflect what I wish to speak about. So I hope you'll pardon me for that. I will now, I'll now share my screen.
But you will talk about Da Vinci anyway.
I will be talking about robot-assisted surgery anyway. It's just the subtitle that that's a little different. Okay, I hope you can see the screen.
No, we are seeing you, and in the background we are seeing your first slide. So I think you have to rearrange your tab and pick it. We are seeing
now?
your whole screen.
Are you seeing the screen now?
No, we are not seeing the slide. We are seeing the slide as a small part of the whole screen.
Just wait. You okay now?
No.
Oh dear.
So when you open the SAS screen, no, you will have to click only on the. Have you opened your PPT?
Yeah, it's fully open.
You will have to click only on that, because what we are seeing is your whole screen. So that shows me also on the screen, you and your presentation only as a small part of the whole screen.
Okay. Give me a minute. Let me restart.
Yeah, I think that will be fine. No problem.
Still no?
No, it shows Rajiv Bhatt has started screen sharing. So I think it will take a few seconds to come up. So this does happen. We already had tested a few minutes back only. It was working.
But I'm wondering that why.
It should come up. Again, the same thing. We are seeing you and multiple images of the whole screen. What you can try is log out and log in again into Zoom. That works sometimes. Yeah, we are seeing the same message. Rajiv Bhatt has started screen sharing.
Okay, still no. Then I'll log out and come back in again.
I think that should work. We'll wait.
Okay.
No,
Okay, I'm so sorry, everyone.
no, it's okay. It does happen.
Can you hear me now?
Rajiv, I can see only the half screen of your presentation. Rest of the half is occupied by other images. Yeah, I think now it's clear. Yeah, it's coming up. Great.
Are we okay now?
Yes, perfectly.
All right. So,
now.
so I will be talking about robot-assisted surgery, and for us, it is setting new standards in oncology. And what I'll do first is that I'll try to give you an understanding of what a robot actually is, and how we then use it in surgery.
Rajiv, we are not seeing your video. If you can switch on, it will be helpful. Otherwise, it's okay. If you find that
1 second, I'll just have to
your video only. But if it is not working that way, we are comfortable with what was going on. No, again, the same thing has happened. Allow app to Zoom us to use. No.
1 second.
Yes, now we are able to see slide as well as you also, and we are able to hear you well. So
All right,
please.
fine. So,
So-
as I was saying that I will first talk about what a robot is exactly, and how, briefly what the evolution was and how we are now using it in surgery before I come to its specific applications in oncology, and then try to balance the use versus the the enthusiasm and the so-called market hype. The word actually originated from the Czechoslovakian word robota, which meant forced labor or slavery. And essentially, it was a reflection of the Central European system of serfdom at that time, when a tenant on the farm would pay for the rent in terms of forced labor or service, much like the zamindar system that we had in India. And it's interesting that it was prevalent in the 19th century all over Europe, But it really gained prominence by this particular play that was written in 1920 by a Czechoslovakian writer, Karel Čapek. And he titled it Rossum's Universal Robots, where Rossum was a scientist who was a brilliant scientist, but hell-bent on production and manufacturing. So he has this factory where they produce artificial humans who would do exactly what was asked of them by the master. And in that play, he showed that subsequently the control escapes the human, and then the robots take over. Now, mind you, this was 1920, much before the subsequent onslaught of films that we saw, Terminator and Robocop and all of these. And at that time, at the premiere in 1921, he had an interview by the newspaper. And I very much like this particular comment that he made, that the product of the human brain has escaped the control of human hands. And it was true at that time, although it was purely an imagination, but we are seeing it now the world over. And he actually called this the comedy of science. And I find this very interesting that, science can be a comedy as well. But anyway, that's the origin of the word robot and how we use it today. So what does this actually mean? Does robotic surgery completely replace surgeons? And there was a very interesting editorial given out by the American College of Surgeons last year, where they explained that, of course, it's a futuristic idea, and today we're using it in many types of operations. And what does need to be emphasized is that it's not the robot that does the work. It doesn't actually do the work. The surgeon actually does the work, and he uses the robot to guide the actions. So I'll show you how that actually happens. But the popular belief is that, like we have our house robots that we ask them to clean the floor, that they clean the floor while we have a cup of tea. It's certainly not the case with robotic surgery. And the machine in and of itself cannot carry out surgery without direct human interaction. And this is very, very important, because if such a thing should happen, then maybe Čapek's prophecy will hold true. That is why we say that it is robot-assisted surgery, not robotic surgery, robot-assisted surgery, or robot-assisted minimally invasive surgery, or RAMIS for short. So it's actually a form of minimally invasive surgery. And as the title of that editorial, the American College of Surgeons very clearly said that robotic surgery is here to stay, but so are surgeons. Now, worldwide, there are currently 6,700 installations of the Da Vinci surgical system. And this is the one that is the oldest and the most well-known. And more than 10 million surgical procedures have been performed using this surgical system. In India, this was a statistic last year, 152 systems with more than 70,000 procedures performed. When I took the last update in July, this had gone up to 175. And the number of procedures have gone up to almost about now 80,000. So there is a exponential increase in the use of robotic surgeries, not only worldwide, but in India as well, we 25% increase a couple of years back, and we are seeing that increase year on year as more and more hospitals acquire the technology and as more and more surgeons are capable of using this technology. Now, this particular system, the Da Vinci surgical system, was created by Intuitive Surgicals. And originally, actually, it was around World War II that the Defense Research Analysis Wing of the American military teamed up with Stanford Research Institute to be able to create a system where they could guide surgeons who are on the front line in the war to be able to do certain complex surgeries sitting back in the US, and the surgeons would actually be performing the surgery at the front line. And of course, subsequently, it underwent a lot of modifications. And I think the real impetus came after 2003 when Intuitive Surgicals took over Computer Motions. Computer Motions was handling the software. So without that software, the hardware really was of not much consequence. But it was after 2003 that it really picked up. And subsequently, there has been multiple upgradations, multiple generations from the Da Vinci S to the SI to the XI, and the latest generation version is the X, which reflects the capabilities of XI pretty much, but it has been made more affordable. So now we are seeing more and more installations of the X in India, and our hospital also has an X system. The system actually consists of three parts. One is the surgeon console that you see on your left. The surgeon sits here and actually performs the surgery. This is the patient side cart, which is next to the operating table. And you see that the X version has got 4 arms through which the instruments are used after putting in trocars into the patient's abdomen or thorax or wherever it is that we are doing the minimally invasive procedure. And then through those particular trocars, the instruments would move to and fro around each other, and all the movements that are necessary for performing the surgery. And this is the vision cart wherein we see the screen, the diathermy systems, all the electric generator systems, as well as the camera system are within this vision cart. But more importantly, the vision cart also has the actual nerve center or the software, which controls the to and fro between the surgeon console and the patient side cart. So essentially what happens is that the surgical robot operates on the principle of teleoperation. It's a master-slave concept, much like the original term use, that the master has to be one and the slave is the robot. And the master is essentially the surgeon sitting at the console, and through the control system, the surgeon's movements and his use of the pedals are translated by the software into actual movements by the individual arms. And you see that the arms are jointed at multiple points. And this is what gives the surgical robot its flexibility and its capability that is much superior to traditional laparoscopic surgery, which doesn't allow for all of these movements in all the directions. These are the kind of instruments, and this is the kind of movement that we would get inside. Not only that, whenever the instruments move inside, the software then translates back the image, which is a magnified image up to 10 times that the surgeon views through the console. So essentially, in one corner of the theater is the console, and you have the traditional operating table, the anesthesia trolley, but you also have the patient side cart and the robot that is next to the patient. And generally now we have one bedside or operating table assistant who inserts and takes out the instruments as and when required. Now, what does this robot do for the surgeon? I mean, how does it really benefit us? And it enhances our capabilities because it stabilizes the motion and reduces tremors. If you see an individual human hand, there will always be very, very fine tremors, however steady the hand may be of the particular surgeon. And with age, these tremors are bound to increase. That's the normal process of aging. The system here nullifies those tremors and translates very stable movements into the arms. It also scales the motions so that the precision tasks can be done very appropriately. So, a very small movement will be scaled appropriately to reflect that particular task that we want to do within the patient with the robotic arm. And of course, it gives us a much greater awareness, and this is when what we call, the haptic feedback. It's visual and it's also by touch. But as opposed to open surgery, one doesn't actually feel the tissue. And this is the only one slight sort of drawback for traditional surgeons like me, because we generally like to feel the tissue before we cut, or we use that to guide some of our movements. Here, there is that loss of touch, but it's more than compensated for by the rest of the system and the magnified view that we get. Navigation assistance with the anatomy is now available, but it's not actually been marketed with the system in the current generation. And they also are working on a warning system that can alert critical events. For example, if you're too close to the vessel, you're using an electric current which might create a hole in the vessel, then you would be warned of this event in time. So it's much like the near miss that we know in our NABH and quality control. And perhaps one day, certain specific subtasks will be automated. For example, if I have a tissue that needs suturing and I position my arms accordingly, and then I can just automate the robot to be able to do a mechanical stitch like you have a sewing machine. But this is where we have to be very careful and remember Čapek when he says that this could turn out to be a comedy as well. I will now show you a very short video of how this actually functions. These are the movements. This is the vision. This is the diathermy pedal. These are the instruments going in and out. And the instruments work on a pulley system, and that allows movements in all directions. And you see, our hand movements are very small, and we control the diathermy there. And these are the instruments actually performing this surgery. One of the advantages of this system is that the electric generator is a very advanced generator. And I have had the experience of using multiple electric generation systems. And I'm, of course, a big fan of, Valley Lab or Covidien. I have been ever since I've trained. But this particular system is an Irby system. And it is phenomenal in terms of the amount of currents that it can give and how we can use these currents in terms of cutting and coagulating. And you see, all of these particular modes are available to us based on whether we want to cut more, coagulate more, we want to blend using various types of currents. So it does allow us a lot of flexibility. And I find that it is somehow a much more effective electric diathermy system than the one that we're using in open. And these are the particular instruments. This, of course, is a vessel sealing system that is available with the robotic. And this is the entire instrument. But what is unique about the robotic instrument, it provides what we call 7 degrees of freedom, which means that it will allow multiple movements at multiple axes. And you can see the in-out movement, rotation, what they call yaw and pitch. And you have one joint here, you have another joint here. So it gives you complete flexibility. And they say that this movement translates into 540 degrees of movement. So, sometimes it will be even much more than than our wrist movements. And, because the wrist will lock at some point. Whereas these instruments will have the flexibility of moving all the way around. This is the laparoscopic sealing system, which you see is essentially a very rigid system with movement only over here, in, out, and rotatory movements. which you can handle with this. So this is the distinction between the same instrument used laparoscopically or open for that matter versus used robotically. Another big advantage that we have with this is the fluorescence imaging that is inbuilt. They call it Firefly. They've trademarked it Firefly. And we use it in a number of applications. You might remember my original talk about sentinel lymph node biopsy, where we have started using ICG, which is a fluorescent dye, to pick up the lymph nodes in the axilla and whether that would need a completion axillary dissection. Similarly here, we have the same system and we use ICG that is injected into the bloodstream. And of course, when a laser light source is shone upon it, you will pick up signals from tissues, and these are picked up. And using this, we can see lymph nodes, we can see the vascularity, we can see blood supply of the organs. And this is just an example of how one would see it at doing a colorectal surgery. You will see the inferior mesenteric artery and the branches there. And this is in Firefly mode, showing you that very clearly. This is the colon. You can check the vascularity also, and you can see that the green shows that it is vascular up to this point. And this is the devascularized area, so we know where to cut and allow for an anastomosis to happen effectively. This is the clipping of all the blood vessels, and you can see that it's all completely sealed. Now, the obvious question is that how does this have an advantage over open surgery? How does it have an advantage over laparoscopic surgery, if any? So over open surgery, it's the same advantages that a minimally invasive procedure would have over open surgery, that there is a faster recovery, a shorter hospitalization, a much reduced blood loss, there is a reduced incidence of surgical site infection, more precision and accuracy. All this will translate into better outcomes with less complications. So actually here it's a no-brainer that minimally invasive surgery is clearly going to be superior to open surgery where it is applicable. What about with lap surgery? Because that's the big thing. You see, laparoscopic surgery now has been widely used in India for the last 2 decades, 2.5 decades. And we have some excellent surgeons who perform very good laparoscopic surgery. And they have evolved on this system. But the robotic surgery system is one step ahead in that it provides a 3D magnified image within the console. The camera system is very stable. If any of you have actually witnessed or done a laparoscopic surgery, you will see that the most common dialogue is between the surgeon and the person who's holding the camera. You know, bring it closer, bring it out, bring it here, put your camera in. You know, this is the commonest conversation that goes on. And if it is the open surgery, that conversation happens with the anesthetist. Please adjust the light here, this way, not that way. And, you know, senior surgeons like Dr. Jagdish Patel will remember that this was the commonest dialogue that they were using in their operating rooms. But here, the camera system is completely within the control of the surgeon. So it provides an extremely stable operating field. And the instruments are the EndoWrist instruments. And as I told you before, they provide 7 degrees of freedom with tremendous articulation at all the joints. Physiologic tremors are filtered. You have motion scaling functions. All of this is not available in lap surgery. The other big advantage that I find is that the retraction is much stronger than in laparoscopic surgery, and there's a fixed third arm retraction. So you don't have to keep telling and yelling at the assistant that, you know, retract this way, retract that way, retract more, retract less, you're pulling too much. All of this, generally we don't hear when we are doing a robotic surgery. And of course, there is tremendously improved ergonomics. And I'll just come to this point that it's not only the surgery per se, which is much improved, translating into better outcomes for patients, but also for the surgeon, it is much better doing this surgery than doing lap surgery or even open surgery in terms of the ergonomics. Now, all is not hunky-dory. I mean, there are going to be some disadvantages of robotic surgery. And one of the first is the anesthetics challenges that it poses, because, you know, we use extreme positions to be able to access the organs, the difficult to reach areas. And, you know, pelvic surgery, we generally do with extreme head-low positions. This places a tremendous demand on the anesthetist to be able to accommodate the changes, the physiological changes that would ensue with such a position. Of course, the lack of haptic feedback is a major issue, as I already alluded to. The duration of surgery is increased because now you don't have a completely open operating field wherein everybody can put their hands in and speed up certain aspects of the surgery. So there is an increased duration of surgery, and this has been borne out by a number of scientific papers. And of course, there is an increased cost because these instruments are expensive, apart from the capital cost of the robotic system itself. And very interestingly, there is lack of surgical community support because, as happens with any new technology, most surgeons are reluctant to acknowledge that it is going to be of use first. And then when they do acknowledge that it will be of use, they are reluctant to bring it on board for a number of reasons. And pretty much after another decade, it will be in use everywhere. That's the normal story of innovation. But this does remain a significant factor that although this technology is available, has clearly shown its worth over other minimally invasive techniques, there still exists a lack of significant support in the surgical community. Now, coming to oncology, where are the current indications? And, GI cancers, we use it at all of these, for all of these cancers, as you can see. Then urology, I think one of the biggest applications has been in prostatic surgery. And now the gold standard for prostatic surgery is a robot-assisted nerve-sparing prostatectomy for prostatic cancer. And it has completely revolutionized the way that prostate surgery is seen and done. Head and neck surgery, oropharyngeal and laryngeal surgery, it has a tremendously valuable role. I'm not too convinced about the other three, but time will tell whether it is being used at a lot of centers. It is being used. We haven't yet any experience in using it for thyroid or neck dissections. Thoracic surgery, of course, it's very useful, and we've used it in lung surgeries, and it is amazing in the way that we can finish the surgery surely and much more effectively. Gynecology also, breast, again, I'm a little bit hesitant about its application in mastectomy, but nipple sparing subcutaneous mastectomy is now done at very few centers in India, very early experience. And we have not yet attempted. The reason, I'm just reminded of one of my very senior teachers, Dr. Vasant Patel. Many of you might be remembering him, but as an intern, I used to go there just to, learn the clinical skills. And he used to tell me that never be the first to attempt something new. At the same time, never be the last to discard something old. And that has stayed with me throughout my life. So I think this mastectomy, I have still to reach a point where I feel that it will be justified. So, like with any new technology, we have to balance our enthusiasm with a healthy dose of skepticism. And with this balance, we'll be able to use the technology much more effectively and hopefully avoid what Chapek had forecasted. Now, there are many other companies which have got robotic platforms. In India, we've got 3 other companies, Versius from the Cambridge Medical Systems, Medtronic recently came out with Hugo, and of course our own Indian innovation, the Mantra. So essentially it was brought in for cardiac minimally invasive surgery, but now they have started using it for other general surgery applications as well. Reflecting the increased use of robotic surgery, the number of publications have gone up exponentially, as you can see, in this 11-year period. And all of this has contributed to the scientific literature. I'll now just briefly look at about 3 or 4 evidence-based papers, which will tell us exactly where we should be fitting this into oncology. And I think this is one of the most important studies, the RECORE study, which was a meta-analysis where they went through the entire literature and 199 references were included, including 7 randomized trials, 23 databases, a lot of prospective studies, and of course the majority were retrospective studies. But the numbers were huge: 157,000 robotic procedures, 68,000 lap, and 2.34 lakh open procedures. So this made very interesting reading. It was published last year. But briefly, the conclusion of 2 decades of literature review showed that for cervix, it shows similar long-term outcomes. For endometrial cancer, robotic was favored. For lobectomy of the lung, prostate cancer, and for low anterior resection, clearly the meta-analysis favored robotic surgery. This was another study which looked at all the randomized trials, meta-analysis of very large single-center studies. And this clearly showed that there was better outcome for robotic TME versus laparoscopic TME in a number of parameters. The oncological rates also were much better. Margins were much better. There was better outcome for robotic versus lap APR in this particular single-center study. But I think the most important has been the reduction in the urinary and sexual complications, because we are able to see the pelvic autonomic nerves much better with the magnified view, and therefore are much more certain that we have been able to spare or save these nerves so that urinary and sexual function is much better maintained. Now, this was another very interesting paper which said that it is of benefit not only to patients but to surgeons as well. And I was alluding to this a little earlier when we talked about ergonomics. You see, here the surgeon is seated with a very clear and a very stable view and essentially just moving the hands. Anybody who has attempted laparoscopic surgery, who does it on a routine basis, will remember that they often come out with shoulder pain, wrist pain, elbow pain, back pain. Open surgeons always have a problem with their backs unless they are very particular about the way they do their exercises. I know that Dr. Jagdish Patel is very particular about that. So I don't expect that he would have had any back problems. But most surgeons tend to have back problems precisely because of the way they operate, either open or laparoscopic. And here clearly the ergonomics is so much better. And there have been a few studies looking at the physiotherapy visits of surgeons in major hospitals that have robotics, and they have reduced substantially after the introduction of robotic surgery. So clearly better for the surgeon, better for the patient. This particular report was another one which looked at 3 randomized trials, 8 non-randomized clinical trials, and the robotic group clearly showed much more outcomes that were improved compared to laparoscopic surgery. I won't go into the specific details, but the complication rates were less, as also the oncological outcomes were also shown to be better, including the higher number of harvested lymph nodes. Now, I'll quickly show you a couple of videos to let you understand what exactly happens inside. And you can see the pelvic nerves over here, which we can save and then do the TME. This is another view which allows us to go deep into the pelvis and very clearly get the planes. And you see these instruments are very strong, very good. The diathermy is extremely effective. So our movements have got to be extremely careful to reflect this. This is another situation where we have now resected out the colon within the abdomen. We are using Firefly to check the vascularity. And you can see it's coming up in green right up till here, so that we know that if we cut anywhere on this side, we will have a vascularized colon, which can then be anastomosed to the rectum. And this is the staple. The staplers are also extremely good, much better than the ones that we use in open. They call it a Shore form stapler. This is dividing the rectum at the mid-lower junction. And you can see you have a completely clean end, and then the colon is anastomosed with a circular stapler to that rectal remnant, completing the low anterior dissection. Even in colonic surgery, if we need to do an intracorporeal anastomosis, the suturing is much easier compared to laparoscopic or open surgery. For gynecology, this was an interesting paper that came out from Tata Memorial Hospital that looked at the increasing uptake of robotic technology in gynec surgery. And this included a lot of benign gynae surgery as well in centers which have the robotic system. But for malignancy, it clearly has shown to be very beneficial, especially for endometrial cancer. The Firefly allows us to do the sentinel lymph node biopsy to determine whether we need to do bilateral pelvic node dissection for endometrial cancer or not. And I think this is a big plus point for the robotic system. As far as cervical cancer is concerned, there was some time back a couple of papers which showed inferior outcomes with laparoscopic Wertheim's radical hysterectomy compared to open. And then the guidelines suggested that we should not be using laparoscopic surgery for cervical cancer. But with the robotic system, the interest has now been regenerated that we should be able to get adequate parametrial and paracervical clearance. And this particular single center study clearly shows that the overall survival and DFS rates are perfectly acceptable. So now, robotics for Wertheim's hysterectomy is making a significant comeback. This is just, again, a couple of short videos showing you the anterior bladder dissection. And the ovarian pedicle dissection. The spaces open out very well so that we can actually dissect much better and in a much more cleaner and more precise way. Ureteric dissection, ligating the uterine at the root. Shows the vaginal vault closure and the pelvic lymph node dissection as well. Some lag in the Now this actually shows the procedure as it happens in our OT. This is the vision card. This is the screen. This is the surgeon sitting at the console and doing the surgery. This is the patient side cart. And here is the view that you were seeing on the screen. So this is an actual video of the procedure as it happens. Now, a couple of quick words about training. We would require to follow a specific training process that has been set up by Intuitive to be able to use the system. Yeah, I've had to go through this system as well. Please remember that the actual surgery is the same, whether you do it open, laparoscopic, or robotic. It's just that we have to learn to use the technology to be able to deliver that same kind of surgery. And this is a very rigid and a very specific system that they have created for us to be able to do before we can actually perform routine robotic surgery. And two of our surgeons, including myself, have now completed this, and we have now close to 60 robotic surgeries performed at our center. We do a lot of time on the simulator, fine-tuning our skills. We've worked on the laprocator as well, and this shows you just gives you an idea of how we've been doing it. This is the way the arms are moving, and we're just doing some suture practice here. But this is the way the arms will actually move in during the surgery. Finally, let me end by showing you where robotic surgery in cancer has shown definite advantages in terms of the ease of surgery as well as in the patient outcomes. So I think the low anterior resection APR with TME clearly in carcinoma rectum has shown to be superior. Nerve-sparing prostatectomy, partial nephrectomy for renal cancers, mediastinal tumors, any lung resection, transoral surgery for pharyngeal wall tumors, base tongue malignancies, endometrial cancer, and of course the pelvic lymph node dissections. And emerging areas that are showing clear-cut advantages is stomach cancers, colon cancers, and retroperitoneal lymph node dissections. So this is where we are currently with robot-assisted surgery in oncology. And I will end here and hand over back to Satish for monitoring the rest of the discussion. Thank you very much.
Thank you, Raju. That was excellent and sort of fascinating presentation. Actually, in fact, we had the talk on robotic surgery by one surgeon from Nadiad, Murjibhai Hospital, some years back, when we had used to have physical Saturday Club meeting. Jagdish Bhai would probably remember. So it's good to know more advances in the robotic surgery. So now we keep the house open for discussion, comments, questions. Yes, Jagdish Bhai.
I have two questions, Raju. How long it took for you to train from open surgeon to robotic surgeon? The time period it took. I saw the process which you showed. Another question was that when we do end-to-end anastomosis, the tension we put on the suture, we feel and give adequate tension on the sutures while doing anastomosis. How do you manage that with robotic surgery?
Yeah, I think both very good questions. See, it generally takes us up to about 3 to 4 months to complete the initial part of the training before we can actually start using the robot. So we do a certain number of hours on the simulator. We have to answer a couple of tests that are online, and then we have to go down to Mangalore to their dry and wet lab to be able to do the surgeries there under guidance, and then for the person to give us approval and all of that. So it doesn't take very long because see, it's essentially learning the technology. It's not learning the surgery. So and that is what Intuitive does. And actually, it is much easier transitioning from open surgery to robotic surgery than it is from lap surgery to robotic surgery. Because with lap surgery, you've grown used to a certain amount of movement and certain directions and all. For someone like me who uses lap infrequently, I use lap only for gynae oncology. I don't have the capability of using it for advanced surgery in the upper abdomen. And we use it in thoracic esophagectomy mobilization. So we're using thoracoscopic mobilization prior to that. But predominantly, I have transitioned from open to robotic, and it has been extremely, I would say, it has been much easier than what I would have thought. So it's much easier to do that. As far as the suturing is concerned, when we are training, we there is a certain method that we follow to allow us to gauge the tension on the knot. That is what you're saying. And there is a way that we are able to gauge that tension. Having said that, a lot of the anastomosis that we do are now with staplers. So it doesn't generally happen that we do intracorporeal anastomosis hand sewn. But of course, we do need to suture. But there is a way in which we can understand that the tension is adequate now. I don't get the same feel and the same satisfaction as I would in open surgery when I put my finger on the knot. But yeah, there it is.
Are there any mishaps, I mean, which can happen, or this is too perfect a system to go?
No, mishaps can happen. I mean, you might have all read about one particular mishap in the UK wherein the robot was somehow left there and the surgeon went out for a cup of coffee and it created havoc. That was a cardiac surgery actually, where it moved inside and caused the death of the patient. But no, generally that doesn't happen because in this system, unless your head is into the console, you don't get control over the robotic arms. So that kind of a mishap generally cannot happen unless one is extremely careless or negligent. Mishaps that can happen is that if you are, if you have a major bleeding, then you have to undock and immediately go in open. So you do lose time there. But with this training and all, and I think, during open surgery, we have a sense of how close we are to the vessels and how we should be using the electric generating system. We haven't yet experienced anything like that. I think in our 60 cases, only one case we had to convert to open because of the duration of surgery that was so excessive that we felt that we shouldn't persist robotically. But otherwise, generally, we don't have these mishaps.
Console is in the OT itself?
Sorry?
You are sitting in the OT only? I mean, with
in the OT, in one corner of the OT with the console. So rather than the surgeon being at the side of the OT table, we are sitting at the console. Now the console can also be put outside the OT.
Right. Because you mentioned about telesurgery, so we hear a lot of things about people operating across the continent through robotic surgery.
Yes. And that was in fact one of the first demonstrations a couple of decades back when the system came in. That somebody sitting in New York was operating on a case in France or vice versa. I don't remember what, but yeah, that is certainly a possibility. Right now, most centers worldwide have the console system within the OT itself. There, you see, you're still dependent on the signals and the internet and all of that to transmit the motions.
So this console and these arms are wired, I mean, or they are wireless connections?
No, the patient side cart and the nerve center, they're wired. Yes, currently they are wired. You're right. I dare say that the future will give us systems that will become wireless. But currently they are wired. So we've got to make adequate space on the floor for the wires to go from one system to the other.
How you change the material, suture material, feeding?
No, the suture material is essentially the same. We use Vicryl and all that. The stapler, the robotic stapler is what they call a Shawform stapler, and that uses different cartridges. But it's pretty much like the linear cutter stapler that we have in open surgery. Only that, it provides multiple layers of the staple, so it's much more secure. And the closing pressure is much better. So you get a very good seal. But no, surgical materials essentially, otherwise suture materials all have remained the same. Generally, for example, for pelvic surgery or vault closures, we use barbed Vicryl, which is also used by laparoscopic surgeons whenever they are doing hysterectomies or any such other surgery. It's just that we have to cut the length of the suture material accordingly so it can be carried through the arm, through the trocar rather.
Any other comments or questions? Okay, so thank you once again, Raju, for very informative
Not at all. You're welcome. Thank you.
session. So we meet next Saturday again. We will have Dr. Varsha Shah, who is going to talk about lifestyle science. She has done some course from Vellore, and she's a pediatrician, but she told me that she is working on this for last couple of years and would like to share some interesting observations and thought processes on lifestyle. So we meet next Saturday morning again. Thank you all for joining. Thank you.